Hi, everybody, and welcome back. We are going to start out this training discussing what is normal versus what is abnormal behavior. Now, I have to caution you because those terms, normal versus abnormal, are very relative, right? And it comes down to social definition in most cases. Social definitions change over time. So what was once abnormal might be considered mainstream at this point. So I want you to keep in mind that just the idea of how we define what is normal behavior is going to always change over time, right? And therefore it's going to impact diagnoses. But identifying abnormal behavior, how do we define that very nebulous term? What's abnormal? We do so through diagnosis of symptoms. And symptoms are going to be a cluster of behaviors, a group of behaviors that fall outside what we define or what society generally agrees upon is healthy and normal behavior. And those symptoms are going to be associated with mental illness. Now, symptoms for mental illness tend to fall on a spectrum. And I want you to understand that symptoms for mental illness are also dynamic. Dynamic means that, they change. It changes. It doesn't remain static. It can change over time, right? Symptoms wax, symptoms wane. If there are an increase in life stressors, you're going to likely see a spike in symptomology. Consistency of medical treatment is also a big role player here in that spectrum. How often is this person receiving treatment? How compliant are they with their treatment? So if they are seeing a doctor, if they're getting medication, how often are they taking it? How consistently are they taking it? So all of these things are going to impact where on that spectrum of intensity an individual is going to fall with mental illness. In order to formally define mental illness, we have formal diagnostic criteria. And all of that formal diagnostic criteria comes from what I call the Bible, right? That's not really it, but that's what I call it. It comes from the DSM, which is short for the Diagnostic and Statistical Manual of Mental Illness. This is literally a comprehensive, very large text that lists every identifiable mental illness, all symptomologies, and then the criteria for what constitutes a diagnosis. So what I mean by that is, for each mental illness, they will list a range of symptoms that have been identified as affiliated with that diagnosis. Just because you have, let's say there's 15 symptoms, just because somebody demonstrates 3 doesn't necessarily mean they're mentally ill. However, conversely, you don't have to demonstrate all 15 in order to get the mental illness if there are 15 criteria. And in the DSM for each mental illness, they're going to list, in order for somebody to receive this diagnosis, they must demonstrate 12 out of the 20 characteristics that are listed here. This can be very nebulous because what if you demonstrate 11 out of 20? Are you mentally ill or are you not mentally ill? So there is some level of subjectivity there. Certainly, if you're demonstrating 11 of those characteristics, not 12, it doesn't mean that your life and your behavior is not impacted in a way that can be debilitating, even though you don't meet the formal diagnostic criteria. So that's something to keep in mind, right? The DSM will define, like I said, it'll define how many symptoms are necessary. And the point of the DSM and the point of diagnosis overall is treatment, right? The idea here is we want to identify what the problem is, and we want to see, okay, so now we know what's going on. We know what the problem is. How do we treat this? How do we minimize these symptoms? How can we control the aberrant behaviors that manifest as a result of the mental illness? So there are so many different approaches, but there are sort of your heavy hitters for most mental illnesses. And one of those that we're going to start with just talking about briefly is pharmacotherapy, which is, it's going to be medication, right? There are a range of medications that are on the market, from antidepressants to anti-anxieties to antipsychotics, that are used to treat to treat therapies, mental illness. There's also different forms of therapy. There's talk therapy, which is your traditional psychotherapy, which looks to, identify problems, develop skill sets for coping and for managing. There's a really sort of big therapy du jour right now, which is called cognitive behavioral therapy. It's a go-to for a lot of mental illness treatments, and it focuses on identifying harmful thoughts that ultimately lead to harmful behaviors and therefore changing both. We're going to talk about that, as a treatment for many of the different mental illnesses that we're going to present. And I want you to understand that these approaches and these treatments are specific techniques and practices that look to mitigate symptomology. We are looking to lessen those external signs of mental illness that become debilitating and interfere with everyday life. Okay. And in very extreme cases, we can have very invasive therapies, although the mental health community doesn't make active use of this as much as they did in the past. But things like inpatient treatment or commitment, electroconvulsive therapy, it's used sparingly, but it is still out there. Okay. One of the big concerns that you as a first responder are going to need to keep in mind and that you're going to come across in the course of your duties is that a lot of treatments for mental illness can what we call poop out. And that is not a medical term, but it is the vernacular that the mental illness field uses, that literally it was working for a period of years. It was minimizing symptoms. The individual was, having success at controlling their mental illness symptomology. Their life was getting better. The functioning was really good. And one day, boom, it just poops out. It stops working. That medication no longer works with your body chemistry for whatever reason. And we don't necessarily, there's a lot of different theories as to why this happens, but we can't really pinpoint exactly why it happens or who it's going to happen to. This is very individual. It's very unique to the individual's biochemistry. It can also be very frustrating and very destructive to the individual's treatment because they may have responded really well for a period of time, had great stability in their life, great success in their life, and boom, all of a sudden it doesn't work. And now medical clinicians have to play with new pharmacotherapy and give this individual new treatments to find out what works, because not all medications do work for every single person. And some medications work better for others than they do for this group of people over here. So it really is it's a science and an art, right? Trying to find successful pharmacological treatment for the mentally ill. And it is a very dynamic process in that just because you're having success in one instance with one drug doesn't mean this will last for the rest of your life, right? And that takes time. It takes time trying out those medications. A lot of new medications or medications in general are going to come with side effects that are unpleasant and that often result in noncompliance of medication taking. And this is when we see people's symptomology flare up, right? And we see aberrant behaviors come out. And that can result in a lot of instances where first responders are going to be called, to manage the behavior, to manage harm or damage, physical damage that came as a result of the behavior, to help calm the person or sedate the person down if they're in a state of psychosis that, sort of flew out of control because they're not medicated. So I want you to understand that, yeah, treatment is the overall approach, and we have made massive advances in the past 5 decades for treating mental illness, but we still have a long way to go, and it's far from perfect, and it's far from, game over. Here's a pill and you're all done and you can go home and you're good. No, it's not, unfortunately, not that simple. Okay. So we are going to cover several categories of mental illness. We are not going to cover every single diagnosis in the DSM because there's a whole litany of diagnoses that you probably will not come into contact with, or if you do, it's really superfluous. It won't impact your engagement with members of the community, but there are many that will. And so we're going to go over the different categories and we're going to look specifically into those categories at what it is that we're going to cover. So we're going to cover cognitive disorders, which cover things like delirium, dementia, which is an ever increasing problem in our aging population that our firemen, our policemen, our EMS are going to come into contact with. Amnesia, not as common, thankfully. Seizure disorders and developmental disorders. We're also going to cover psychotic disorders, which is going to cover schizophrenia, delusional disorders, brief psychotic breaks, and schizoaffective disorder. Again, a lot of EMS and policemen will come into contact with individuals who fall under those categories. We're going to look at mood disorders, which looks at major depressive disorders and bipolar 1 and 2. Anxiety disorders, it's good to have a good contextual knowledge and background of people who suffer from anxiety disorders. These people are not violent, but they can be very difficult to communicate with and engage with. We're going to look at generalized anxiety disorder. We're going to look at panic disorder. We're going to look at post-traumatic stress disorder, something that the first responder field is very familiar with, as many people in the first responders category can suffer from this themselves, having that excessive and consistent exposure to trauma and to stress. And finally, we're going to look at obsessive compulsive disorder. under the anxiety disorder category. We're also going to look at somatoform disorders. This is going to cover things like hypochondriasis, conversion disorder, pain disorder, body dysmorphic disorder. A lot of these, members of EMS are going to come into contact with. Police are going to come in, be called a lot, especially for people who fall under hypochondriasis or conversion disorders. So that's going to be a common interaction. And finally, we're going to look at personality disorders, which covers the following, which is schizoid personality disorder, schizotypal, paranoid, dependent, avoidant, histrionic, narcissistic, borderline, and antisocial personality disorder, which most people recognize under the term of psychopathy. In addition, we're going to look at substance abuse disorders, which is going to be a central part of all first responders' engagements. And we are also going to look at childhood disorders so that you have a working knowledge of what to recognize among children who have cognitive disorders and behavioral disorders, and how you can understand where that behavior is coming from and how you can communicate with them better.